Okay, so hello and welcome to this evidence session for ARMA's MSK Health and Inequalities Inquiry. We know that the incidence of MSK conditions is not equal. There's inequalities related to age, to sex, to ethnicity, social and economic deprivation, a whole range of different factors. This inquiry, we felt we needed to focus on something because otherwise it becomes too complex, and so we are focusing on socioeconomic deprivation. We're currently at the stage of gathering evidence to produce a report, and the report will be completed at the end of this year and launched early in 2024. The launch will be the second phase of this project, which is about disseminating the recommendations with the aim that they are implemented and we can actually make a difference to health inequalities. I'd like to thank our supporters. So thanks to Grunenthal UK Limited for sponsorship of the project, and Pfizer Limited, Novartis Pharmaceuticals UK, and Janssen, who have supported the project through charitable grants. Supporters have no say in the way this project is run. So although we know that the incidence of MSK conditions increases with age, it's important to remember that some MSK conditions do develop during childhood. We know that socioeconomic deprivation leads to poorer health outcomes for children and young people, and we know that that's also true for MSK conditions. So in juvenile idiopathic arthritis, JIA, for instance, deprivation is associated with higher rates of diagnosis, higher likelihood of a more severe impact, and also has implications for transition to adult services. So this is a really important evidence session for our inquiry. We have received a certain amount of evidence around children and young people, and this session will allow us to explore those issues in more depth to ensure that those issues are reflected in our final report. So today's session is part of our evidence gathering, so please feel free to add your views to the chat and ask questions as well to supplement the questions that I will be asking the panel. But today we're going to hear from two people with slightly different perspectives on this question. It's a great pleasure to introduce Jacqui Clinch and Anne Hagell. Jacqui, could I ask you briefly to introduce yourself and say what you're interested in this area?
Sure, thanks, Sue. So welcome, everybody. I'm Jacqui Clinch. I'm a consultant paediatric rheumatologist with an additional interest in young persons' musculoskeletal pain. I'm Vice President of the British Society of Rheumatology, representing our paediatric and adolescent community across the UK. And my interest here really is a personal but also a community dedication to erasing inequality of access to good care for paediatric MSK health. We know that it's impacted from our personal experience, but also from feedback from colleagues across the United Kingdom.
Thank you very much, Jacqui. And Anne, would you like to say a little bit about yourself and what gives you your interest in this topic?
Of course, it's great to be here. I'm the research lead at the Association for Young People's Health, and we are a charity that raises the profile of young people's health needs and promotes youth-friendly health services. And dealing with tackling young people's health inequalities has been a major part of our work in recent years. We've been part of a large health foundation funded project on reducing young people's health inequalities, and we've built a data hub around that and done some deep dives into particular groups of young people who seem to be especially disadvantaged. And so that's really where my interest comes from. My background's in psychology and public health, so the sort of data side of it is very important to me, but I work very closely with colleagues who do a lot of voice and engagement work with children and young people, so that's also really critical to how we understand what's going to work for children and young people at AYPH.
Great, thank you, and thank you for bringing your expertise to this session today. And perhaps I could start with you. Could you just outline what are some of the factors that mean that socioeconomic deprivation can lead to poorer outcomes for children with long-term conditions?
Yes, of course, and of course, it's not a simple answer to that question, and I think there are different categories of factors that and we're talking really about the translation. You've had the diagnosis, and then we're looking at poorer outcomes at a later stage. As you mentioned, that there's also inequalities around being diagnosed, but this is sort of once you've got the diagnosis, why might you have a poorer outcome later if you fall into groups where you don't have as much money, basically. I mean, some of that is obvious practical and resource issues around getting access to services. So the cost of things, the cost of travel, the amount of money that people have available to just even get their access to public transport. Some of that comes with areas of multiple deprivation will be less well served by those kind of transport systems, so that it's harder to get to appointments. I think also, though, there are some sort of other issues that are around the kind of stress that these families will be living in, and the challenges that raises for being organized, being able to give time to this. You're being pulled in a number of different directions if you are a parent who is unemployed or struggling with low income, and I think also potentially more stress on the children in those situations. So you also will get intersectoral issues around, more likely to be children who are carers in areas of high deprivation, or children who are care experienced, who have sort of layers of difficulty that they're dealing with. And I think organizing yourself, learning to deal with a diagnosis and how to manage it as a teenager in those situations, I think is challenging on a number of levels. I think there are also issues around trust in services, and that if you've not been well served, and things have been very difficult for the family, you may be less inclined to trust other services. And so I think we have to work particularly hard at that. And I think services unintentionally can sometimes be structured in ways that make it difficult for people in these situations to get the access that they want. And at AYPH, the model that we follow is really around access to services. That seems to us to be the really key central part to solving, or at least ameliorating health inequalities for instance, adolescents, which is the age group we mostly work with, who have long-term conditions. The more we can do to reach out to them to counter some of the problems that they're having in terms of access, the more hope we've got.
Thank you. And that resonates with a lot of the evidence we've been getting, not just around this age group, but for all ages, about the importance of services reaching out. Jacqui, did you have anything you wanted to add to that?
So I can make it very rheumatology MSK centric, I guess, and maybe I saw two patients. Just make it tangible. I saw two patients in my clinic yesterday. So one is a young 9-year-old boy who has been diagnosed with a very rare MSK disorder, which is inflammatory as a baby. It's an Afro-Caribbean family, single parent in private housing association accommodation. He has visual impairments as part of his condition, mobility issues, and although a high learning, a high cognitive functioning, high IQ, access to actually education from his home is tricky. And he was just made homeless and evicted. His family was last week, and is now in a hostel in one room with 5 siblings and his mum. So that's him, and his 2 bus journeys away from us in Bristol. And the other one is a teenage girl who's got a diagnosis of rheumatoid arthritis, who lives with her grandparent, who has her own care needs, and my patient's a carer for her grandparent, who does not have arthritis but other problems, and her ability to access us is extremely limited. She also has period poverty, which means they cannot afford sanitary products despite a lot of effort, I think, socially putting into this. And so she does not come to our clinic at any time that she thinks she may be having a period, because she can't afford the products and therefore uses other means. And our examination from an MSK, we must remember, for all these children is pretty intrusive, because we need to look at all their joints. And sometimes that's forgotten, particularly with adolescent girls. So they're the 2 scenarios. I think the main areas that we see in our communities, I think we need to look at delay to diagnosis, health literacy, resources in poorer communities, healthcare resources in poorer communities, the ability to get to primary care, the ability for parents to take time off work, and recognition of symptoms in all these areas are markedly reduced in those poorer income families. And although not ghettoized, they are increasingly large, these areas, with increasingly poor healthcare primary resources. And that gives a delayed diagnosis. So we need to really look at that, I think. And we know in arthritis in young people, a recent publication last year showing that polyarticular juvenile idiopathic arthritis in those communities has a significantly reduced outcome, both due to delay and then access to hospital appointments when they've got a diagnosis, and then transitional care into adult services. Part of that is a reduction in workforce in our own area, which is a different topic. So those are the particular areas we need to concentrate on. And I think as an MSK community, particularly looking at this whole lifespan approach, which I really embrace, because if you get it right, particularly in these communities early, then the outlook for them as young adults with employment and their own income is good. But get it wrong in these in these situations, then unfortunately they become lost to follow up, and their healthcare needs, both physically and emotionally, increase. So, broad subject, but I think there are key pinch points that we all can work together to understand and improve.
Brilliant, thank you. And I just wanted to explore a bit more this issue that we have had some evidence submissions on, which is about the accessibility of services. So we particularly heard about travel distances, and that, I think that's particularly relevant in paediatric rheumatology, because the services are quite specialist, and so there are not necessarily at your local general hospital. But we also heard things about the need potentially of having evening and weekend appointments and slightly more flexibility around the timing. So, Anne, was there anything else you wanted to say about exploring those physical access issues a bit more?
Yeah, I think though that is really, really critical. I think in addition to those physical access and the sort of financial and bus route kind of barriers that are put up, I think it's really important to think about, as Jacqui sort of indicated, the life stage that that young people are at, particularly for adolescents, for instance. And I think access to services can be improved by understanding what lives are like for teenagers and fitting services around that. So we hear a lot about the expectations on teenagers, for instance, that they attend clinics that are run during school time. And for working parents, you can take time off work to attend a hospital appointment. At school, you can't even get time off to go to the dentist at school without there being a sort of penalty. And so, you know, knowing that that's the kind of pressures that people are under, and that these pressures will be increased for those who are living in socioeconomic situations for all sorts of background reasons, I think is really important. I mean, we're very much in favour of the general sort of principles of youth-friendly healthcare across the board. So people may be aware that the Department of Health revised the You're Welcome quality criteria for youth-friendly healthcare just earlier in the summer, and that sets out 8 different criteria to help you make your services accessible to teenagers. Those kind of general criteria will help people who are, you know, living in areas of high deprivation as well. And they're to do with things like flexible clinic times, drop-in facilities for this age group. And I think another issue is understanding the perspective of young people. Your services will improve if they're informed by youth voice. You know, if we know what young people think and say, that is a way of improving access to services, because we may not, from where we're sitting, completely understand what those barriers are. And so I think that kind of communication and improving the way in which you're supporting staff to communicate with teenagers is really key to improving access to services. And a lot of young people, the relationships is what is critical. you know, they want people who will understand confidentiality and consent and feel confident about that. And again, that can be particularly important if you're living in a very stressed environment. You don't want other people to know about, you don't want your teachers to know things. So knowing that the staff understand consent and confidentiality and can communicate with young people is important. Now, that's not easy and does require a sort of acknowledgement that staff need to be trained in those sorts of communication skills, but as well as the sort of transport issue, I think those things are really important to improving access to clinics for young people in these situations.
Can I add to that?
Yes.
I totally agree. I think I'm noticing, and colleagues are noticing, a higher DNA, so did not attend, in all ages, not just adolescents. And I think never has been a wider gap between those that have and those that have not than now. And never has there been a wider gap between what happens in health and what happens in social care and access to good social care. And so many of our younger children also, parents are unable to take time off work, and schools are becoming, I would argue, these young people, particularly from poorer communities where their voice may be not as well heard, they're getting judged quite quickly in school as taking time off. Bearing in mind, a lot of children have many therapy visits, and all those therapy visits are in hospital: physiotherapy, occupational therapists, psychology if you have access to it, as well as hospital visits, and they really add up. And so a parent in a poorly paid manual job is not going to be able to keep that job. They are not able to keep that job if their child with arthritis has multiple hospital visits, particularly the younger ones. And there aren't the other carers around or other parents around who can take that child instead of the main carer. And that's getting worse, much worse. And so I think we need to really try and address this. Now, we all want great social care, and there's a lot of talk about social care and healthcare coming together. We're so far away from that if we can think within our MSK community about how to try and help those families access us, but also our services going to them. And I totally agree, we need an evening appointment service. It's madness for adults with arthritis or MSK conditions and for young people. And we need to get a much longer day in our hospital settings. But taking therapies out to the patient or nearer the patient, I think will be enormously helpful, so that their ongoing therapy care can be much nearer to them, so they don't need to always come to hospital. And that will help healthcare, travel costs, etc.
Can I add again? So you must just stop us from.
No,
Jacqui and I could go on and on. I was also going to mention access issues around transition from paediatric to adult services for teenagers who are sort of 17 and approaching that cutoff. And I think one thing that we've heard a lot of anecdotal information about, and we've did a bit of work for NHS England recently on this, is if you don't have a parent advocate at that stage and you don't feel confident enough yourself to do it, you can fall into a black hole there between services. And we have quite a lot of stories of young people who've missed out on, a year or 18 months of service because they're too old for paediatric, too young for the next stage, or that something's gone wrong in the link between the two. And so I think understanding that these kind of communities perhaps don't have the same advocates there to do that liaison with services is really important too, and we might have to step in and compensate for that for children who we know are coming from backgrounds where their parents are either not there or are completely distracted, unable to put that time in, or just don't have the confidence with services. It's fine for me to ring up doctors and berate them for this, that and the other, but not everybody has that the sort of background that gives them the confidence to do that.
Brilliant. Thank you both very much for that. And it's resonating with other things that we've been hearing, particularly the one about bringing the therapies closer to the communities that they're serving. So one of the things that we've been hearing from services about is the barriers they face. We asked, what sort of barriers do you face to tackling some of this? And one thing that comes up a lot is data. So one clinician said to us that they've got an anecdotal understanding of deprivation within their area, but they don't have any data to verify that. And also they cover a very wide catchment area. So they don't necessarily have the full knowledge of that area across all of the parents of the children that they see. Jacqui, have you got any thoughts on that point?
Sorry. Many thoughts. We are across the UK starting to capture data better. That's my first comment. We've got a program rolling out, Capture JIA, just juvenile arthritis, so not wider MSK, but it's giving an idea in regions about the key, the top problems addressing that region, about how we can help the flow of young people get earlier care, how we can look at those problems and find solutions. So data is being now collected. We haven't got it yet. It'll be a couple of years. So I would like to think that we will be further on very soon with understanding it. I think data is extraordinarily important, and coding in hospital is woeful. And so, but primary care data is much better collected. And so working with primary care while trying to improve hospital coding of different aspects of care, I think is the way forward. I don't think data is the whole area we need to look at, though, because if we wait for good data to come in, I'm worried that it will stop us starting to put things in place that we already need to be fixed. And I think working with other charitable partners, working with government, working with patient partners, we can already start. We already know the areas that we could really look at. So yes, data is important. Yes, we're starting to collect it with JIA. Have we got enough? No. Will we have more in 2 years' time? Yes. But it shouldn't stop us. It shouldn't stop us moving forward in the areas we know need to be improved. I guess that's my slightly woolly answer to that, Sue. I'm sure Anne will have much better clarity.
Yeah, Anne, have you got anything to add on that one?
Well, again, lots and lots of thoughts on this. There are extraordinary gaps in the data, and when we did the program for the Health Foundation, we built a data portal, data hub, which has a range of statistics around health inequalities for young people, and it was really quite shocking how we had to scrape around to get what we needed for that. I think often what services missing are good local data, and even at the local authority level. And there are some resources available, such as fingertips, for instance. If people are aware of fingertips, which is OHID, Public Health England, or Public Health England data, what is the word, a thingy board, and benchmark sort of statistics, and those do actually give us quite a lot of information about socioeconomic data in the local area. So they give you a sense of what it is your area might be particularly struggling with. I think the new NHS Core 20+5 approach also will really drive better data collection, since it's those plus groups, the plus 5, what are your local 5 groups who are particularly experiencing health inequalities in your area. That will focus people's attention on collecting data about those groups, and those groups will vary by area. So some groups will have particular issues. There'll be, for instance, in Kent, refugee and migrant children, which won't necessarily be such an issue in different parts of the country. So getting a better grip on the local situation, I think, is important. I do think there are simple steps that services can take that we're not always taking at the moment, to just find out who is coming. I agree with you, Jacqui, that the data in public health are better. but it's actually really difficult to extract information. I want information about the quinary age bands for about 10 to 14, 15 to 19-year-olds out of primary care. That's not available to me, and you know, as an outside researcher. And but if you ask, you know, if you ask a little bit about the people you are seeing, people can actually build a picture of who is coming, who is struggling, just sort of keeping track of those kind of issues, and then identifying some of the gaps and targeting particular attention. And then it's also really important for services to collect feedback from children and young people. And we quite often recommend that people just do friends and family for children. You know, if you're not already doing that, just begin to get really, really simple data about what did they think was difficult, just so that that's really specific to your service, and you just get a bit of a picture. What it is more hard to find out about are the groups you're not reaching. So the groups in the community who are not coming to your service, who are not pitching up in some of the hospital episode statistics and things like that. The fingertips data do address some of that, but we're not completely there yet. But I do think that getting a better sense of your local picture, because that does vary. And the whole thing about core 20+5 is, you know, the 20% in the most deprived areas obviously is an issue all around the country, but the +5 groups are really important to tailoring your service.
Just coming back to the local thing, so the Capture JIA thing is exactly that, and so it's each region, there are about 13 tertiary paediatric rheumatology hospitals, and if you are in an area like I represent, the southwest, then if you live in Cornwall, it's a 3.5-hour trip to Bristol, which is their nearest tertiary paed rheum centre, and so each centre is absolutely getting family feedback, young person's feedback, and the clinicians' feedback about, you know, their own regional challenges and how best to rectify them with the tools they have. So I really hope that will be very informative. And I see Emily and Debbie and others are on the line, and Lynn in the chat, who know this better than I do. That different regions have different challenges, but we all have similarities as well: access to high cost drugs, access to good therapy services, and a large bit of work on equity of care and access to mental health well-being and psychology support for parents as well as their young people. So I think we are absolutely more insightful. We are getting the data through. I do feel we have enough now to really make inroads while we are continuing to collect even better data. I guess that's what I'm feeling.
But as you pointed out, Jacqui, the primary, presumably for those people who have that kind of distance to their tertiary centre, you know, primary care and the GPs must be holding quite a lot of the sort of in-between care, and also encouraging them to understand who it is they've got coming to them. You know, that is a part of the health inequalities journey. If people can't get through the primary care bit, they're not going to get to you. So making sure that all the stages in that pathway understand the inequalities and who it is that's particularly facing it in their area is important, isn't it?
It's vital. It's vital, and I think I could probably hear some eye rolling in some of the audience on this session, and that it's so variable. It's so variable within the same street with primary care access, let alone wider than that. And we have to remember always there's a community belief. There's still a big belief out there that young people don't get joint problems. There's still a big belief out there that it will pass. There's a greater understanding that young person's arthritis and MSK disease, we know it goes into adulthood. During my time as a consultant, when I started 25 years ago, we thought it burnt out. Most of it doesn't. And so this understanding and our own health literacy, and those of our patient partners and families, we have to keep on that, and so that people are all understanding better.
Yeah, agree.
Brilliant. Thank you very much. Jacqui, you briefly mentioned social services and social care, but one of the issues that has been raised with us is the lack of other resources to refer children and or families too when they need more than just medical support. And a comment that often the people who the clinicians see as being in very high levels of need don't actually meet the eligibility criteria for some of those services. Have you got any thoughts on that, or any experience of trying to get wider support?
Oh, so much experience of trying to get wider support. Yes, I contacted the patient I talked about yesterday who'd been evicted, the MP, just before I came onto this. Oh goodness, so much despondency, actually, Sue, I have to say. What can we do? Well, I have put some thought to this. So I think these young people need advocates. I think, particularly from poorer communities, social workers are so overwhelmed. Their brief is so huge, and I wonder whether we, as an MSK collective, across all our professional areas and with our patient and charitable partners, need to think about how can we advocate for these young people with MSK disease in a way. It's like a stepping stone to social workers. How can we empower people to have a voice, to receive the resources that they're entitled to? Because I tell you, it took me 2.5 hours to get through to the housing association for this young person who has so many health needs. And somehow we need to flag up those young people that are really vulnerable. And we need to flag it up collectively, not aggressively, not despairingly, but just saying, look, I've got many patients. These two, my goodness, they really need your help in social care. And I just wonder if we can work collectively to get a pathway, healthcare advocates, social advocates, something that certain families are given access to, that we drive collectively. Because I feel so woefully inadequate as a consultant, ringing the same line that everyone else is ringing, trying to get help for these young people. So it's a plea, I guess, to work together with everyone else who's on our chat.
Brilliant, thank you. And Anne, have you got anything else to add around this one?
Well, I agree with Jacqui. It is hugely frustrating and depressing for practitioners in the middle of this, not knowing, what to do. And it is a really difficult issue. And I know, we have also heard anecdotally often from people in primary care that you don't ask some questions because you don't want to know the answer to it, because it will just unearth something that you will then feel that you need to sort out, and you don't have the time or the resources to deal with it. So you sort of deal with the whatever it is, headache, joint ache that has come in, but you don't actually scratch the surface and find out more about those background factors that need solving, because it ends up being your problem to solve, and you haven't got the time or the resources to do that. And I agree about the role of brokers like healthcare advocates, of having people. We have because we focus particularly on the adolescent age group, quite a lot of interest in the role of youth workers in health services, and there are a number of pilots going on around the country at the moment of placing youth workers in different parts of the hospital system in order to pick up some of the more vulnerable young people and advocate for them and solve external issues. So I don't know if people are coming across them. It's not arthritis related, but Red Thread, who do that in emergency in departments. So they'll have people embedded into accident and emergency departments who will pick up people coming in with particular issues. They're bound to have issues of deprivation around that, such as people coming in with stab wounds and things, and then work with them for 6 months to make sure that they are connected, because the healthcare people can't deal with that. So I think those kind of brokers is probably a really key part of providing the bridge, Jacqui, between the services, as you indicate. I do think it does rely a huge amount on the personal relationships and discretion that is available. And I know a lot of clinicians have, you know, really exceptionally good relationships with some parts of the voluntary sector around them, understanding your local voluntary sector, what charities there are in the vicinity of your service is really important, and getting to know the staff there so that you've got a sort of direct line in, and building up trust does help people, I think, get hold of you know, some of the things beyond the statutory social work. Statutory social work is an absolute disaster. Statutory youth work doesn't exist, and the voluntary sector is the bit that's picking up the pieces. So, but it's a really imperfect system, and of course, young people don't understand why they, you know, that there aren't central data systems for all this as well. Why they have to keep telling their story again and again and again to every service that they go to, and that's off-putting and creates more barriers. It's a tricky one.
I totally agree. I think having, if we were to go down, I mean, this is ripe for piloting. If we could come up with a pilot in this area, we know that young people who are on biologics in poorer areas don't have decent fridges to keep the medication in. They can't have someone at home to wait in for the home delivery. We know that actually home care deliveries of our drugs at the moment are dreadfully policed, in that they're often late, they're often got the wrong amounts in them, and in some cases they're being delivered the wrong drugs completely. So in an imperfect system, if you're poor, it's so much worse, because you haven't got the ability to vocalize your concerns in a way where you feel heard all the time. You haven't got the ability for someone just to have a day off and stay at home, and you haven't got the ability to have the fridges or whatever to store those drugs in. And add into that, if you're someone where English is not your first language, or you have some learning complications, then you're already at a disadvantage. And again, you don't have those bridging services that allow you to understand the forms to fill in. You may have really poor online access. You may have no broadband. You may have one iPhone between 6 people in a house. I think it's like you're kicked to every point, kicked down. And often these communities are in areas where public transport is very poor to get to the hospitals. You mentioned access to tertiary, and I mentioned access to tertiary. The primary care for our young people does not play that much of a role when a young person has arthritis. It's the district general hospitals that play the bigger role, normally in outreach. So we have outreach clinics in DGHs, and then we have tertiary hospitals. It will be phenomenal if primary care could play a bigger role, prescribing drugs that at the moment they're not prescribing, having paediatric phlebotomists in a primary care setting, and maybe having access to paediatric MSK physiotherapy and OT from primary settings. That would be a game changer for so many of my families in Devon and Barnstable, Cornwall. So I think there are a lot of changes that fiscally, I would argue, would make a difference for society. I think in the end, we'd end up not admitting so many young people who are in crisis to a tertiary hospital. I think we wouldn't be taking parents away from their workplace so much that they had to give up, and all other areas. I think it would be sensible. I've ranted there, Sue. I was worried that I'd rant on this webinar. I'm ranting.
No, that's good. We like ranting. That's fantastic. No, that's really useful. Just before I kind of come to the kind of what else might we do bit, a couple of things that have come up in the chat, and please do keep the chat going. That we're getting lots of rich information from the chat as well, which I will make sure I save before the end of this. One of the things that somebody raised was around children who are going away to university, and that being a long way from your home GP and potentially, I guess, your home hospital as well. I don't know if either of you have any thoughts on that one. I know that certainly it's a major issue for people who are going away to university who need social care support. but are there solutions to this one that are health related? I don't know if either of you would like to comment on that one.
I can comment. You know that we were involved in a bit of work liaising with universities and also workplace environments for young people with MSK conditions, and we did a combined bit of work with many patient organisations and yourself, Sue, and the government in supporting the workplace in universities. So I hope that will be helpful going forward. It's only, as you know, only published last year. But more importantly, I think, again, the social disparity comes in here. So we know the GP always moves. So when a young person goes to university, their GP moves. The GP doesn't stay in their home address with their parents. What is variable is who looks after their MSK condition when they go to uni or college. Because the GPs, and those of you who are parents of young people who have gone to university may have come across this. Actually, the primary care near the universities are very, it's just a reactive service. If a young person has a problem with their general health, you go to the primary care. They won't be that well versed in the condition that they're coming to university with, because that all stays in their local hospital and their local tertiary hospital. And therein lies a problem. And it's something absolutely we could look at across all our young people with MSK, not just those who have disadvantaged financially or otherwise. We know from Helen Foster's work, who wrote a lot in this area, that actually the educational outcome for young people with arthritis, particularly if they're from poorer backgrounds, is significantly worse than peer-related without arthritis. And so I think there's a great deal of work generally to do about education and further education for our young people. And this is not the webinar to go into that, but there are many factors that we can help with, not least good control of disease and support in making decisions about where they want to go next with their education or career. So yes, we've written a bit. Yes, still a lot to do.
Thank you. And Anne, did you have anything to add?
No, I think that's all exactly right. There has been quite a lot of interest in the Royal College of GPs adolescent health group about the university situation and about the possibilities of perhaps dual registration for young people with long-term conditions, so they retain the home as well as the university. You get a lot of anecdotal information from GPs about the pile-up of issues that people will come back with at Christmas for the home GP and then have to do a temporary registration across the Christmas holiday just to sort out all the things. And terrible stories of parents driving medication 400 miles up the motorway, having collected it from the local GP and having to get it up there that evening, kind of thing. So yeah, something needs to be done around all of that. And I think some of these issues are generic to long-term conditions, not specific to musculoskeletal. We also get that with diabetes and epilepsy and young people going away from home with those kind of conditions and just needing more support.
I think also shouldn't ignore the mental health of these young people. So when you've had any chronic condition, and JIA affects mobility and your mental well-being, that's been beautifully shown by our charitable partners. It's that going to university for all young people is almost like the greatest social experiment. You could take an 18-year-old who hasn't fully developed with their brain yet, and you put them in a different city with different people at this really vulnerable stage of their life. So that's it. Well, that's much reported in the press and in our own experience. But add into that a long-term condition like arthritis, where actually you have to have medicine that you have in your own fridge, in your own room. You're already different. My goodness, the mental health impact is phenomenal. And a primary care physician with the best will in the world, my goodness, to cope with that. So that dual registration would be invaluable. And also, and this is about disparity and those more vulnerable. If you're a young person from a poorer background who gets to a further education or university, there's a likelihood that family won't have a great experience in young people going off to university, and therefore that kind of catching at home is not going to be as well developed as it is in other families. And so that's another factor that actually pushes them away from going to university or continuing university. We know more young people from those backgrounds but drop out through many factors.
Yeah. And I think the mental health point is really critical. And we hear all the time from young people that they don't make the same distinction between physical and mental disorders as you know, our classification structures do, and our medical qualifications do, that for them a long-term physical health problem inevitably has impacts on their mental health, because they're at a stage of development where, you know, relationships to their peers is critically important, and this interrupts their ability to do everyday life. And I think that is something that contributes to poorer outcomes for young people from more financially deprived backgrounds, because something that will come with that is probably the experience of more trauma and you know, disasters having happened that will predispose you, whether you've got a long-term condition or not. You probably, you know, you need your resilience bolstering. And so to think that we can solve the tangle of issues here without addressing the mental health part of it as well for this age group, I think is probably a mistake.
Brilliant. Thank you both very much for that. So just kind of coming towards the end of our time, are there any other steps that you think services can take to help reduce these health inequalities, or steps you'd like to see local health systems like the ICBs take to address health inequalities? Don't know who would like to start with that one.
Well, just on the larger bit, rather than the individuals, I do think there is a role to play for structures like Core 20+5 and also quality criteria, just making this part of everyday business for people. You have to have attention to health inequalities. You need to develop youth-friendly health services, and that's built into the, you know, the how we rate and consider services. That sort of just making sure that those kind of levers in the system are used. It is quite difficult to advocate for young people in health because they're, you know, they don't die very often, generally thought of as a well age group. You know, we've done 0 to 5s. Let's wait until they're a bit older and deal with the rest of the problems then. So getting a sort of focus on this age group generally will help health inequalities for this age group, advocating for them and making sure that systems are encouraged to recognise that, I think is really important. And that's something the ICBs can do. That can be built into their own needs assessments, their ways of you know, commissioning and rating services in the area.
How long have you got? I've got loads of loads of. I'm just noting some of the chat as well. Okay, so I think health literacy, and Emily mentioned it in the chat, but I've got it on my list. Health literacy is really important. We are traditionally really bad consumers as a society of health, and by the nature of the beast, people who advocate, who are on the charitable boards, who are in these forums, we are all very health literate. But the people that we represent, many are not. And to improve health literacy and improve support for families who are looking after these young people, whatever age, doesn't matter whatever age, is really key. So I think we need to put thought with partners on how we can best support parents and carers making the right decisions, making good decisions, making informed decisions on behalf of their young person. And that goes across all of society, I think. It's particularly an issue in those deprived areas. So somehow we need to get health literacy support into our deprived areas, in a way that they can make good decisions for themselves and their children, which will impact their outcomes, their health outcomes. And it's how we do that, whether we do it through signposting, whether we do it through digital, whether we do it through healthcare hubs, close to them. I'm a great believer in face-to-face rather than digital. If we have a healthcare hub in most areas, but particularly in areas of low income, concentrated it in the areas where there are troubles, difficulties, so that almost like a drop-in service, MSK service. Andy Bennett and I and you, Sue, and others have talked about this, having hubs so that people can drop into these areas. I think that'd be enormously helpful. I think having representation from low-income families on our boards would be really helpful. So we have fabulous youth boards with Banner, with VA, with Lynn Woolley and others. Having representatives from those who are from very low-income families, so that they're at the table and they have a voice, would be really important, and inform us on how we do this. Lobbying, so that there's easy access, lobbying government, easy access for these people to have help with transport, help with accessing good IT, help with benefits so that someone can be there to get the healthcare at home delivery. I think there are all these areas. I've got a long list. I'm not going to go through it, but there are all these pinch points I mentioned earlier. I think we can get in together with our partners, but we have to lobby and we have to have a loud voice, because we can't rely on government to do it for us. As you say, people don't die, but they are greatly disabled, and it has enormous impact on mental health. So we need to be their advocates.
Yeah.
I'll have a look at my list.
Thank you. And we've had a question in the chat, which sort of relates to some of that, which is about how can we work to better find out directly from those living in deprived communities what would help them in managing their children and young people's healthcare needs. Are there ways of reaching those communities?
Sorry, Jim.
I was going to say there are, and we're for instance doing quite a lot of work with NHS England on young people with a range of different long-term conditions, specifically to try and reach communities of young people who experience more marginalisation, for instance with diabetes, epilepsy, asthma. It's what I would say is this is not cheap work. You need really highly skilled engagement people to do that. You need to work really closely with voluntary sector organisations that are already in touch with those communities. And I think the situation is improving now, but certainly a few years ago, this would get tacked onto grants or tacked onto pilot studies, and without any real resource going behind that. But it can, just to get together a group of young people, we have convened groups of LGBTQ plus young people, those kind of things, requires a lot of time. And the time isn't so much actually face-to-face talking to people. It is because people find it difficult to that their lives are very complicated, very stressful. You have to really go to them, or you have to work how they want to work, one-to-one or in groups. And so to do that work properly, I think costs a lot of money, and that we really need to invest in that. And so that was just one thing that I would say. Jacqui, I interrupted you.
No, you didn't. No, I interrupted you. I think you're absolutely right, but I think it's work that needs to be done. And I think it is the right time to do it. Sue, you could think about doing a piece of work that's 0 to 25 rather than stopping at this arbitrary 18, because I think that captures the whole that whole young person's journey. I think it needs to include carers, and it needs, as Anne says, to be done sensitively and inviting all our voluntary and patient partners to be part of it. And you could do it as, I hate the word pilot because it feels almost like a small version of, but we could do a feasibility, if you like, of 3 areas of the country. That's a complete out of my head number. It could be any number, but actually really doing a deep dive in those areas that's informed by the local teams, a robust evaluation of the problems. So kind of all the focus groups, as Anne says, done completely properly costed, so that we get robust answers that are meaningful rather than a tick box exercise. I'm a bit tired of all the tick box political exercises that go on. If we're going to do it, we need to do it properly for the people that are represented.
And I think it has to be very clear what they get from it and the meaning for them. I think that certainly in the young people that we work with, there's a little bit of an exhaustion with being the young person hauled up to do stuff, and then the situation not improving. They really need to see that this is valuable work and that it results in things. I did, Sue, if I just got a minute just to follow up a question that's come up a couple of times about schools, the role of schools, and I think it's a really tricky one. Because schools are seen as the solution to all sorts of problems at the moment. We're working with schools in New, for instance, on food insecurity, and health has long been something that people would like to situate in schools. And there are some great examples of schools that have managed to, actually run health services on the premises. School nurses is often raised as a possibility. We have something in the region of 1,600 across the country in England, and they mostly cover between 10 and 20 schools. So, they're going to spend 2 or 3 hours a week in each of their schools if they're lucky. So what they've been involved in is things like vaccinations, and to some extent sexual health, but to actually involve them in supporting young people with long-term health conditions is, I think, probably a step beyond what the capacity of systems within schools at the moment. So we do have to think really carefully about how to involve schools. They clearly have the captive audience, and this is all tied up with attainment. What we want for young people is that their conditions don't hold them back, and so education is a key part of that. But that is not an easy nut to crack either. And the schools seem to be getting more and more stressed and more focused on attainment, and so helping them to tackle that, I think, is really difficult.
But health literacy in schools could be a really important thing. So having in primary schools, particularly the children themselves, all the children, and again, particularly in large primary state schools, if the young people had good health literacy, then that would be a step forward.
I completely agree, and it is part of statutory PSHE now. So health. Well, they should be being taught health. How good that is, again, varies enormously depending on who in the school has been allocated that as a task. Getting it embedded into the community of the school rather than something everybody does at 3 o'clock on a Friday afternoon, I think, so that it filters down through everything that they're doing is the most effective way of doing that. As has been put in the chat, there are some examples of good stuff going on in some schools. But again, it doesn't happen by accident, and I totally agree. And the same at secondary. I think it's really critical that health and food are something that secondary schools help to promote.
Brilliant. Thank you both very much. And going back to the work, Anne, that you're doing with NHS England on particular conditions, reaching out to young people. Perhaps now we have a major condition strategy that recognises MSK as one of those conditions. We could get MSK included in that piece of work. So perhaps pick that up. But anyway, thank you both very much for your time today. That has been really, really useful at informing the inquiry, as has what's in the chat, which I'll make sure I save before I close this session. And yes, just everyone look out at the very beginning of next year for the final report, and then we will see what we can do with it. So thank you all very much.
Thank you. Thanks to all the chats and comments and things.
Yes.
That was really interesting.
Very much.